Dr. Nidhi Tandon, and I work at Mazumdar Shaw Medical Center in Bangalore. And my topic for today is how to best manage chemotherapy induced anemia. Anemia is much more prevalent than all of us believe it to be in cancer patients, and approximately 67% of all cancer patients suffer from anemia. Some malignancies, like lung cancer and gynecological malignancies, have as incidence as high as 75 to 80%. Not only does the type of cancer affects the prevalence of anemia, but also the stage of cancer, and you can see that as the tumor stage, nodal stage increases or the disease becomes metastatic, the prevalence of anemia also increases. Most chemotherapeutic agents cause some level of myelosuppression, but few drugs like docetaxel, platinum have an incidence of a grade 3 or 4 anemia in the range of 30 to 40%. So, what is the cause of such high prevalence of anemia in cancer patients? We all know that few cancers, like lung cancers, colon cancers, gynecological malignancies present with some amount of blood loss, and some cancers like hematological malignancies present with bone marrow infiltration or hemophagocytic syndromes, which lead to anemia. But a more important cause is most cancer conditions are an immunoinflammatory condition, and cytokines like IL-1, IL-6, TNF alpha increase the level of hepcidin, which not only blocks the iron absorption from the gut but also sequestrates iron in the macrophages, leading to iron deficiency. Moreover, most of our patients suffer from cachexia and malnutrition, which leads to iron, vitamin B12, and folic acid deficiencies. There are various grading systems to judge the severity of anemia, but what we commonly use is CTCAE grading, and what we must remember is grade 3 or 4 CTCAE anemia, which is hemoglobin less than 8 or life threatening consequences because of anemia, respectively. Does chemotherapy induced anemia cause a delay or reduction of dosage of chemotherapy? Yes, of course. And about this is a study of about 4,000 patients, and it showed that as the number of cycles increased, the frequency of patients with anemia causing dose delay and dose reduction also increased. This is a similar study in 1100 patients of cancer who had completed at least 4 cycles of chemotherapy, and anemia was associated with an increased odds of dose delay as well as dose reduction even after adjusting for neutropenia and thrombocytopenia. Moreover, anemia can exaggerate tumor hypoxia, which can in itself lead to chemotherapy as well as radiotherapy resistance. So, how to evaluate anemia in cancer patients? What we should first proceed with is a peripheral blood smear, where we will look at the reticulocyte count and the mean corpuscular volume. I will not go into the differential diagnosis of micro, normo, and macrocytic anemia, as well as the differentials for low and high retic count. All of us are aware about it. But what is important to note is that we should rule out anemia due to other causes like nutritional deficiency before labeling it as cancer or chemotherapy induced anemia. And why is it so? Because approximately 40 to 50% of patients with cancer have underlying iron deficiency. We diagnose iron deficiency based on the transferrin saturation and ferritin level. A transferrin saturation less than 20% is suggestive of iron deficiency, and a ferritin level less than 30 suggests absolute iron deficiency, while more than that suggests functional iron deficiency, as in patients receiving ESAs. And those patients are the ones which require IV or oral iron supplementation. NCCN guidelines recommend use of iron dextran, sucrose, or gluconate, but what we all commonly use is ferric carboxymaltose. What next? What if the patient's anemia does not recover with iron, vitamin B12, or folic acid supplementation? Then is the time we have to choose between blood transfusion and erythropoietin stimulating agents. So what are the factors that helps us to decide? The factors which help me to decide are hemoglobin level, whether the patient is symptomatic or not, comorbidities, performance status, and also whether I am treating the patient with a curative intent of treatment where I do not want any delay or reduction in the dose. But what should also be taken into account is that if I want a rapid increase in hemoglobin or hematocrit level because the patient has anemia related symptoms, that is the time when I will choose a PRBC transfusion versus when I want a gradual improvement in anemia just to avoid a transfusion is the time we will choose an erythropoietin stimulating agent. One packed cell on an average will increase the hemoglobin level to 1 gram per deciliter or a hematocrit level to 3% if there is no associated hemorrhage. When to start erythropoietin stimulating agents? NCCN recommends below 11, ASCO below 10, ESMO says below 10 in symptomatic patients and below 8 in asymptomatic patients. But what they all agree upon is we should discontinue it as soon as we reach a hemoglobin between 10 to 12. Why? Because there are benefits and risks involved. This was a Cochrane meta-analysis which compared RCTs comparing ESAs with PRBC transfusion versus PRBC transfusion alone, and it showed that ESA reduced the PRBC requirement but increased the thromboembolic event. But that is not the only concern which we oncologists have. The other concern was that up to 2007 there were a lot of studies which suggested that it increases mortality and progression in cancer patients. So this was a individual patient data meta-analysis of around 2000 patients which showed that the overall survival as well as the progression-free survival between patients who received ESA and did not receive ESA remains the same on long-term follow-up. However, the incidence of thromboembolism, including cardiovascular events and cerebrovascular events, increase with the use of ESAs. These were further studies specifically in lung cancer patients as well as in breast cancer patients, which showed the use of ESAs in adjuvant, neoadjuvant, as well as palliative setting is not associated with an increase in mortality among patients with cancer. So finally, in 2017, after 10 years, FDA determined that uh, risk evaluation and mitigation strategy for the use of ESA in cancer patients is no longer necessary. Which one to use, dermapoietin or epoietin? It depends on whether you want a short acting with a daily or once weekly frequency, one versus a long acting with a weekly or 3 weekly frequency. How frequently will you monitor these patients? At least weekly. If no hemoglobin response, that is 1 gram per less than 1 gram per deciliter increase above baseline happens within 4 weeks of epoietin or 6 weeks of dermapoietin, that is the time we do dose escalation. And if the hemoglobin response is more than 1 gram per deciliter in 2 week period, or we have achieved our target of avoiding transfusion, that is the time we reduce the dose by 25 to 40% for epoietin and dermapoietin respectively. How long after chemotherapy should patients continue to receive this? Almost 6 to 8 weeks after the chemotherapy. So this is my summary slide which shows that I assess the hemoglobin. Once it is between 8 to 11, we assess the ferritin and the transferrin saturation to determine whether the patient has absolute or functional iron deficiency. Supplement iron, vitamin B12 or folic acid if required, and then according to the severity of anemia and the urgent need for blood replacement, we do PRBC transfusion or ESA supplementation. Thank you.
Thank you, Dr. Nidhi, for that nice overview on anemia in oncology and chemotherapy patients. You just finished bang on time. We have close to about 150 participants, so I would request participants if they have questions to put it on the chat box, and we'll request the speakers to answer them in due course. They will be there till the end of the session, so questions can keep popping up, and it will be answered by the speakers. We will now move on to the next talk in this session. I'd request Dr. Chandrakant, who's the hemato-medical oncologist at Narayana Super Specialty Hospital, Howrah, Kolkata, to introduce his topic and start. Dr. Chandrakant.
Yes, so thank you, sir, for the introduction, and good evening, everyone. So, in the coming 10 minutes, I will speak on this novel molecule, which is NEPA, which is netipetin plus palonosetron. It is a combination of an NK1 antagonist with a 5-HT3 antagonist, and this is a steroid-free antiemetic regimen, in contrast to many of the other regimens where steroid is there. So, going ahead, we all know chemotherapy. The problem is vomiting, especially if you have a multi-day chemotherapy. There is an overlap of anticipatory, acute, delayed, everything, and the proper regimen, how to position them, or should be the steroid dose, when to use 5-HT3. These are not standardized. We need to have frequent injections, and dexamethasone has to be given over a prolonged period of time, and this will add to immunosuppression, hyperglycemia, steroid toxicities, and all that. So we all would love to have a regimen where we can have less frequent oral administration and a steroid-free one. So, speaking about the molecule as such, which is netipetin plus palonosetron, this is the only fixed dose regimen which we have as of now. They are long acting, just oral tablets every other day, and no requirement of steroids. So this is basically a single arm phase 2 study in patients who are undergoing autologous stem cell transplant conditioned with the beam regimen. So so the so what all we have right now, antiemetics are basically ondansetron or granisetron, palonosetron, which are the 5-HT3 antagonists, and then we have dexamethasone, which is a steroid, and then we have NK1 antagonist, which is aprepitant, netipetant, and so on. So going ahead, NEPA is basically netipetant is a more potent and has a longer duration of action when compared to aprepitant, and palonosetron is the best among the 5-HT3 antagonists as per its potency and duration of action is concerned. And so this is the rationale for combining netipetant plus palonosetron, which are the most potent and also have a longer duration of action, oral medication, less frequent administration, and that is the rationale for a NEPA, or the netipetin plus palonosetron combination. Well, if you look into the half-life and the duration of action, palonosetron acts for nearly two and a half days, nearly 2 days, and netipetin acts for nearly 4 days. So they are long-acting drugs, less frequent administration. And their oral drugs, even the IV formulations are there, but not available in India. So the objective was in this patients with relapsed lymphoma undergoing autologous transplant, especially with this multi-day beam regimen or a FEAM regimen, just is this NEPA, which is an oral drug, giving every alternate day, is it sufficient at all? This is a single arm study, not a randomized study, and the primary endpoint was complete response, that is, no vomiting at all during the study period up to day 8. And there were secondary endpoints like nausea and other ones. So, complete control and complete response in MSS free interval, and there should be no rescue medication. They did, and there was also a patient's global satisfaction rates. So they used metoclopramide as a rescue antiemetic in this particular study. So this is the study regimen. They did have multicentric study. They had around 60 odd patients. You can see the regimen of BEAM, which lasts for 6 days. You can see the NEPA being given every other day, day 1, day 3, and day 5. And metoclopramide was used as a rescue, and this was totally steroid-free regimen as well. So this was the inclusion criteria. for autologous and not allogenic. And this were the assessments. They did assess the efficacy, toxicity, and the global satisfaction. And this is statistical consideration. So to have any efficacy, they should have had a complete response in at least 42 patients. That was their pre-specified efficacy endpoint, and they did report the adverse events as well. So totally we had 69 patients in this study, and this was the age, gender, and performance status, fairly good data. And this was the salvage regimens used, BHAP and RDHAP being the most frequent salvage regimens. And you can see the conditioning regimen and the number of days of mobilization, majority 2 days, and this was the results. So they did attain overall nearly 87%. So the pre-specified efficacy percentage was 42 patients, and here we can see nearly 87% patients had a complete response overall. And if you look at the delayed data, nearly 98% had a complete response in the delayed phase. So if you look into complete control or no MSS or no requirement of rescue, everything above 85%. So it looks like NEPA, which is a fixed drug combination of netividin plus palnosatron, steroid free, given every other day, is good enough even during the transplant setting in the conditioning regimen. Looks very promising, especially when you want to use a steroid free regimen and oral regimen. Again, if you look into the complete responses, from day 1 to day 8, more than 90% had this response, and this was no nausea at all in more than 50% patients as well. And the delayed action was more promising than the immediate action. Again, the same data being shown again, and the toxicity was also fair enough, not much except a little bit of constipation and a little bit of fever seen in a few patients as well. And the global satisfaction was also promising. Patients were compliant, and they didn't report any quality of life side effects as well. So with the safety, so mild fever in few and constipation in few, as we see with other antiemetics also. So to conclude, so we have moved beyond dexamethasone, we have moved beyond ondansetron, we have moved beyond just apropitant. So we have a fixed drug combination of netividin plus palnosatron, and we can see that it has met its primary endpoint of complete control or complete remission in more than 90% patients, and it is more promising for the delayed part of vomiting as well. So this is a study where we can use a steroid-free regimen and just an oral tablet, even in a multi-day chemotherapy, and it is as good as other regimens as well. With this, I would like to conclude. And in our institution, we have the privilege to use this more frequently because of reimbursable patients, and our experience is in par with this study. And thank you so much for the opportunity.
Thank you, Dr. Chandrakant, for giving that wonderful presentation on oral NEPA and its efficacy, and the fact that you also used it and had some experience with it. That's very interesting and very nice for us to know. Questions will keep coming, so I'm encouraging the participants to please post your questions on the chat box. The speakers will answer it as the sessions are proceeding. Now we'll move on to our first panel discussion. The moderator for this will be Dr. Randeep Singh. Randeep, as you all know, is a senior consultant medical oncologist at the Narayana Super Specialty Hospital in Gurugram, Delhi. I request Randeep to introduce his topic and the panel and start the discussion.
Am I audible, sir?
Yes, sir.
Yes.
Can you introduce the panel as I am full screen?
Sure, sir, I'll do that. So our panelists for the session are Dr. Dani Gupta, Senior Consultant Medical Oncologist from Dharamshila Narayan Super Specialty Hospital, Delhi. Dr. Rajit Chanana, Medical Oncologist from Dharamshila Narayan Super Specialty Hospital, Delhi. Dr. Rajiv Saini, Medical Oncologist from Sri Mata Vaishno Devi Narayan Super Specialty Hospital, Jammu. Dr. Sujata Mushrif, Hemato and Pediatric Oncologist, SRCC, Children's Hospital, Mumbai. Dr. Naveen Jairam Anvekar, Medical Oncologist from Narayan Multi Specialty Hospital, Mysore, and Dr. Shilpa Prabhu, BMT and Hemato-Oncologist from Mazumdar Shaw Medical Center, Bangalore. Over to you, sir.
Okay. A very warm welcome and thanks again in person to all the faculty as well as thank you Chairperson and Dr. Sharad. So, as Chandrakant did touch upon multi-day regimen, and there is one of the case presentation about multi-day chemotherapy regimen in the panel discussion. What I wanted to highlight before we start with the questions and discussion is that there is always a gap, and believe it or not, when we sit down and look behind, we will realize that these graphs and charts are true. There is always a gap when the light blue color and the blue and the green color, there is a difference how the patient feels about acute nausea and delayed nausea, and much more difference and discrepancy is in between delayed nausea and vomiting. So definitely it is a concern, and this definitely causes a cost of admission if not managed well and a delay in chemotherapy dosage. So starting with I have mentioned the name of the panelists so that we can be very crisp and the questions are directed to the particular panelist, being it in a virtual, that is a drawback. Starting with Shilpa, there are two questions to my mind. Do we consider patient-related risk factors while prescribing antiemetics for CINV? We know about low risk, moderate, and high risk, and it was already told by the previous speaker. And if yes, what are those patient-related risk factors?
Patient-related risk factors are taken into consideration. These patient-related risk factors include the age of the patient, that is the younger age, female sex, history of previous CINV, and history of motion sickness, history of morning sickness in the previous in the pregnancies, and a patient who has already anxious about these about chemotherapy and history of self-medication and all those things. If we consider this in our practice, we do consider these following risk factors, especially if it is a younger lady and with the previous history of CINV. In all these factors, we try to give a stronger antiemetic agent, and also the choice of antiemetics depends upon the chemotherapeutic, the antiemetic, emesis potential of the chemotherapy agent. That is, for a higher emetogenic chemotherapy, we give stronger, that is triple drug regime of antiemetics.
So Shilpa, I just actually the second question was related to that only. Suppose someone has a regimen which is a moderately emetogenic risk regimen, and they have all these risk factors which you mentioned, or maybe 3 or 4 such risk factors. So will you use the antiemetic regimen of a moderately risk chemotherapy, or you will step up and use the antiemetic regimen for a high emetogenic risk?
No, sir, I will step up and give a higher antiemetic regime, because there is data to show that even in a moderate emetogenic, if the presence of these risk factors, there will be higher incidence of vomiting, and that leads to unnecessary postponing of the chemotherapy cycles, as well as patient complaining and patient having lost to follow up and other associated problems.
So thank you, Shilpa. I think you have made a point that yes, we have to remember that these are not only in the statistics, we have to consider. And a very important point which Shilpa has made is to be remembered, and that is one of the take-home message, that you have a lot of risk factors. Even if you are using a moderately emetogenic regimen, be cautious, and you may even step up and consider that patient as a high emetogenic risk. So Rajiv and Sujata, I think both of them are there. Rajiv can begin, Sujata, in this order. We have many guidelines which are available: ASCO, NCCN, ESMO, MASIC, that is a multi association of supportive care. Institute based guidelines are there, and one of the idea of picking up this topic was that maybe after the collegium, we also someday, when we evolve and do more meetings, we have our own guidelines that we are following in NHPAM centers as these guidelines. So at present, are you following any particular guidelines, or it is all about experience?
So if we see most of the guidelines except ASCO, all the guidelines are using triple.
Hello. Yes, Rajiv, can you hear me?
You are audible, sir. Am I audible?
Yes.
Yes, now
you
yes.
are audible.
Yeah.
Yes.
Sir, basically all the guidelines are using a triple drug regime except ASCO, which is using all the 4 drugs upfront in case of high risk hematogenicity drugs.
Sir,
as far as myself is concerned, I am usually start with the 3-drug regime in such patients. If the patient have any events of nausea or vomiting post therapy, then I used to add 4th drug from next cycle onwards.
So you are following a NCCN or an ESMO based regimen, or an ESMO or MASTEC based. You are not following as per the 4-drug regimen.
Yeah. I always start with the 3-drug regime.
Sujata.
Hi, I'm a pediatric oncologist, and the only official guidelines that have been published really are the Pediatric Oncology Group of Ontario guidelines, which are basically were extrapolated from the ASCO, NCCN, and ESMO guidelines. So that was what my institution during training used. So experience as an institution is based on those with minor differences. So at that time, there was not approval for aprepitant, so we used it only about 12 years of age, not below that. But there is a study from AIMS India by Dr. Bakshi, which has showed it to be safer. So it is 1 month to 17 years in a fairly good number sample size. It was shown to be safer. So I had used it in few patients when there was a lot of MSS with the 2 drugs. A 3rd drug was added. And recently, palonocitron has also been approved for use in pediatrics as young as 1 month old. But I haven't used palonocitron in a whole lot of patients. Had used granicitron before. So basically, it is the Pediatric Oncology Group of Ontario guidelines, which we are using as pediatricians.
Yes. Can you hear me, Ashish and Sharad?
Yes, sir, we can hear you, sir.
Yes, yes.
I'm sorry, I don't know. There was a technical glitch. I was logged off, but I think Sujata has made a comment. If that was audible, I can proceed further.
Continue.
Sujata's comment. Okay,
Yeah,
I
it
will
was
continue
audible.
with the
Continue.
next slide. Okay, fine, sure. So sorry, Sujata, for missing out, but thanks for making the comment. I will just slide. So I think both Rajiv and Sujata were already making this point that there is a varied guideline, and some people use a 3-drug regimen. NCCN gives you a lot of options, but what we have to realize that these guidelines have evolved in a very different way. MASEC is yet to come with the guidelines, so they have given an update. But the latest guidelines of MASEC for 2016, which in 2020 makes it around 4 years old, and we have guidelines in NCCN in 18 and ASCO in 2017, and definitely there is a gap. But what is important is that we stick to one regimen, and both highly hematogenic, acute, highly hematogenic delayed, moderately hematogenic, acute, and delayed. There are different varied guidelines which are used. And if you stick to one guideline, you know what to do in case of failure, and your approach to breakthrough vomiting also varies. And of course, there is a difference when we use multi-drug regimen. There is a difference when a hemato-oncologist or in a BMT, they give the anti-hemetic regimen because most of them are highly hematogenic. So coming to this, Danny, I could see Danny.
Yeah, Randeep.
Danny,
Yeah.
is cisplatin? Yes. These are two questions for you. Is cisplatin highly hematogenic at every dose and schedule? For example, weekly cisplatin 35 to 40 mg per meter square. And similarly, do you consider carboplatin also highly hematogenic? The two plans when we give carboplatin are AUC2 with RT or weekly, or AUC5 3 weekly.
Yeah, Randeep. Regarding if we discuss about the cisplatin, there are two variable doses. All of us know with the weekly cisplatin along with radiation, which we are using commonly along with in locally advanced head and neck cancers, right? Their usual dose is 30 to 40 milligram per meter square, or some are using 50 milligram per meter square. So there, that doses in around 2-3 years back earlier were taken as a moderately hematogenic. But I believe newer guideline recently, every dose of cisplatin, either weekly or 3 weekly or higher doses, every dose is taken as a highly hematogenic. So irrespective of weekly, 3 weekly, higher or lower, so irrespective of doses, any cisplatin will be taken as highly hematogenic drug. And regarding carboplatin, I think more than AUC 4, if we are using AUC more than 4, it will be taken as a moderate hematogenic drug. And here I believe some guidelines are varying. Some, I think NCCN is saying it to be taken as a highly hematogenic if it is AUC more than 4. And about usage of prophylaxis, if we discuss in highly hematogenic drug in cisplatin, frankly speaking, we are using 3-drug regime as of now. We know 5-HT3 antagonist, NK1 antagonist, and along with dexamethasone. And olanzapine we were using for selected patient after when a patient have breakthrough vomiting. Most of the patient were not requiring that, but after going through the guideline, I think I believe we can use even 4-drug regime in high risk category, or even in fact in all patients receiving cisplatin. So that is my take on after going through the recent guideline.
Thank you, Danny. In interest of time, I will cut down, but you have made a very valid comment. The 2 points from what I can give as a take home from your, from your experiences. Carboplatin, most of the guidelines are now recommended as highly metogenic, and I think we all have not been trained to use olanzapine, but we all wish to use olanzapine. At least someone who's failing on a 3-drug regimen and has you have given a 3-drug, a 5-HT3, NK1, and Dex, and then it is a highly metogenic or in a transplant setting, definitely, if possible, olanzapine can be considered. Let us take a case scenario. This is a 33-year-old female with breast cancer. She is a smoker and drinks socially with a regular exerciser. Her medical history is significant for hypothyroidism, anxiety, and GORD, and also nausea during pregnancy. She is planned for an adriamycin and cyclophosphamide-based regimen. And Dr. Naveen, can you help us with what will be your antiemetic regimen of choice in your practice, whether acute or acute as well as delayed? Hi, Naveen. Naveen, there?
Yeah. Oh, yeah. Thank you.
Yes, please. Yes, we can hear you. Please go.
Yeah, this patient being a case of breast cancer, she has multiple risk factors for MSS, like female and less than age 33 years, and also she had motion sickness during her this morning sickness during her pregnancy, and also anxiety is also a risk factor. The only positive factor is she's an alcohol. She consumes alcohol. The thing is, usually I follow the NCCN guidelines, and
So
I
the
usually
message is that all females and all males who are going on chemotherapy shall start drinking alcohol the moment they are diagnosed with cancer. That is what. Please go ahead with your comment.
Usually, I follow the NCCN guidelines, and usually I use 4-drugs regimen, especially for such cases. This one 5T3 the receptor agonist with Dexona, with NK1 receptor agonist, with olanzapine. I use 5 milligram or 1 milligram based on patient age and how fragile they are, age wise.
So Naveen, can I ask you how is your experience? Because the previous two speakers, Danny and the previous panelists, were not very comfortable with olanzapine. How are you comfortable of using, suppose 5 mg olanzapine, and for how many days do you use it? Do you use it for acute and delayed? And can you just tell us your olanzapine experience in very brief and the dose and regimen you use?
Yeah, we have been using olanzapine since our Kidwai days, because in BPL scheme and also this one apripitant they couldn't afford, and the scheme didn't provide. So we have been using olanzapine, and we did studies also on olanzapine. Especially the study was done by Dr. Vinita. And the thing is, we have been using since then, and patient usually tolerate well with olanzapine 5 milligram or 10 milligram. I usually give it from day 1 to day 4, once a day.
Okay, thank you. And I think Dr. Vinita is there in the faculty also. Vinita Binoy, you mean?
Yeah. Vinita.
So I will request Vinita, since she's not there in the panel, but she can put her comments in the chat box about olanzapine. And what will be your regimen for Naveen in the delayed one? Suppose you have used 5-HT3, Dex, NK1, and Olanza. So for the delayed part, the acute part, and for delayed, what will be your choice?
Yeah. If I used this one apripitant, I continue with 80 milligram apripitant on day 2 and day 3. Dexona 8 milligram on day 1, day 2, and day 3, and olanzapine 5 or 10 milligram on day 1 and day 2 and day 3, and so sometimes day 4 also.
So for AC, non-AC, whenever you have high risk factors, you would like to use a 4-drug regimen for induction, and then for a delayed vomiting, you would like to use a 3-drug. If I'm right?
Yes.
Okay, thank you, Naveen. So let's proceed with another case scenario. This is a much more difficult one. A 15-year-old young female has ovarian germ cell tumor, planned for a BEP multi-drug regimen. The regimen which was used for this female was a Dex 20 day 1 to day 5, Palonosetron 0.25 at day 1, day 3, day 5, and fosaprepitant at day 1 and day 3. and day 6, 7, 8, the lady received 8 mg dexamethasone alone. So Sujata, do you agree with this regimen? I will, and Sujata followed by Rajat, or you would like to make a modification to this regimen? I will go behind and put the regimen here. Sujata and then Rajat. Anyone? I mean, Rajat can start if Sujata is not able to.
I was on mute.
Yes,
sorry.
we can hear you.
Yeah.
Yes,
So,
Sujata, please, go ahead.
It's a highly hematogenic chemotherapy with 15-year-old adolescent children usually have a lot more MSS than the younger children in experience. Usually use a 5 mg per meter square twice a day dose. 5 mg per meter square per dose as a twice day dosing of DEXA. I think the dose seems a little on the higher side here of the DEXA to me. I have been using more of ondansetron, and fosaprepitant is if necessary because of the cost issues, but it's available in the formulary, so haven't needed to use
Sujata,
a lot.
You are a pediatric. You are a
I'm a
pediatric
pediatrician.
oncologist.
Pediatric oncologist.
I think there is a data of using palonosetron, and that data is from India only.
I mentioned that earlier. So it is available.
Sorry, I was logged out at that time.
Yes, Dr. Bakshi has this thing published it, and it's safe. Considered this safe. There was initially only a non-inferiority trial, and with 0.2 mg per kg dose as a more significantly useful dose. But when I have used ondansetron has worked fine, so I've really not
and
used.
What is your experience about fosaprepitant?
Fosaprepitant also we have it available with us. Only in case of need we have used it. We are adding it on, but usually only 2 drugs is what we have used, and if necessary, then we add the fosaprepitant mainly because of the cost issue. And depending on the age also, very young children don't have that much as the adolescents and young adults. So I would probably use this in an adolescent and young adult as a third drug.
Rajat, what is your? I mean, you're mainly an adult medical oncologist. I mean, practicing more of adult. Rajat, are you there?
Yes, sir. Actually, I am driving, but I'll still give my answer. I am not.
No, it's fine. I think you do drive. I understand. I know you were in an emergency as in the same hospital. I will take this answer and just take care, Rajat. It's fine. Sure. If you are comfortable, please. And I can take help from Danny also. Danny, would you like to make a comment on the regimen?
Yeah, Randeep. I think here. So, 15-year-old young female with BP regime, definitely this is highly hematogenic. However, I would like to use dexamethasone in a dose of, I think, 12 milligram rather than 20. It seems to be higher.
Yes,
and I'm comfortable with palonostrone 0.25, which we are using routinely. And fosaprepitant is okay, 150 milligram IV, or aprepitant 125 day 1, day 2 80, day 3 80. I think here fosaprepitant on the day 3rd, it's not required as such.
But even Danny, I will say it may be because even in the NEPA, which the Chandrakant just talked about that paper, even in the DMT setting also, of course that NEPA is a different formulation than oral aprepitant, but they had given NEPA on day 1, day 3, day 5. So there is always a conflict, and that is the reason of putting this point. I am also always confused. Palanox, I know the half-life is around 72 hours, and we do repeat it day 4. Fosaprepitant as well as in NEPA, I am also confused whether to give it day 1, day 4 or day 1, day 3, day 5. I would give, if I would have to use, I will use NEPA or fosaprepitant day 1, day 4. But you are right, even
why I am saying so, because whatever regime we are using, this triple drug regime, many trials have said these are effective for even 4 to 6 days. These drugs are effective for up to 4 to 6 days. If we are using DEXA, 12 milligram, palonostrone 0.25, we can repeat the palonostrone this after day 3 or day 5, that is acceptable. But fosaprepitant, I am doubting we should repeat it within a week or so. Yeah, that
okay,
is my
thank you. Fine. So the patient complains of severe nausea on day 3. The severity of nausea is reduced, but it was not fully controlled. The patient had 2 episodes of vomiting. We can call it as breakthrough vomiting on day 5. Young lady anxious, of course, in spite of using the drug, and then thus she was started on olanzapine. And olanzapine was continued along with dex till day 8. The severity of nausea reduced, but now patient is complaining of drowsiness. So Shilpa, can you take this question that what will you do in case of a breakthrough nausea and vomiting?
So because this is the case of a breakthrough nausea and vomiting, we would prefer
Yes.
to use a agent which is not previously used in the antiemetic regime. That would
So Shilpa, sorry, so there are two agents which have not been used. One has been olanzapine and the other has been perinom or domperidone regimen. So how will you use these drugs?
Sir, because on a day 3, you have already started olanzapine at a dose of 10 mg and patient is having drowsiness by day 5, I would like to reduce the dose of olanzapine to 5 mg. Seems like olanzapine is working, but there is some side effect of olanzapine. So I would like to reduce the dose of olanzapine to 5 mg OD. And I would also like to add on metoclopramide at a dose of 10 mg IV, TID, 3 times a
I
day.
agree. And I think there is a difference, and that is what we all have to realize, the way we manage in the normal daycare versus we manage the regimen in BMT, and the way pediatric oncologists manage the regimen. And that was the reason of having Sujata as well as a mixed bag here. There is a difference in the approach, and that is what I am realizing as I am receiving the comments. And definitely, there is no right or wrong. This is what we do it daily. There is nothing but as I mean, nothing which is very difficult, but it is how you use it. Thank you. Last question, and we have some time. We will try to take some. Kashish, do we have some questions? And what is the time left? Accordingly, we can plan.
So there are 8 minutes 40 seconds.
And do we have some questions which you can put it later on from the comments from the chat box?
Sir, I'll just confirm that.
Just see that I was logged out in between, so I have lost the chat, the previous chat. So, okay, Raji, how safe are the antiemetics? And I mean, have you ever worried about your antiemetic regimen's safety? I mean, we do talk about chemotherapy and all others. But, have you ever thought about the safety of antiemetics? And if yes, what comes to your mind, Raji? Rajiv?
Hello.
Yes.
Hello.
Yes. Please go ahead, Rajiv.
So most of the time we use antiemetics without any worry, but in few patients we do have severity of constipation or sedation with olanzapine, and in few patients where we are using steroids in diabetic patients or other who are very sensitive to steroids. These are few incidents where we usually modify our regime. Otherwise, in most of the patient, I never thought about the adverse effect of these agents.
Okay, fine, fair enough. So I think what we have, since we are using more of granisetron and palanosatron, we are not worried about the side effect of ECG monitoring, as you said. But if you remember the previous, this was one of the the warning by FDA, and this was regarding Zofran, which was the original ondansetron about QT prolongation. If you see the QT prolongation on the left-hand side, palanosatron does not cause as much, but ondansetron and granisetron definitely causes the QTC prolongation. Though I have not yet encountered, but I am using much more palanosatron than the other 5-HT3 antagonists. Also, if we can go back about other side effects, I think what I have realized in using very high doses of ondansetron definitely causes constipation and headache, and we tend to miss about these two side effects. QTC is worrisome. Netipetant and aprepitant are safe, but yes, it is known to cause thrombophlebitis. I have not seen myself, but I have heard from my colleagues in the meeting that aprepitant IV, fosaprepitant, can cause severe thrombophlebitis at time. So I think with this, I would like to thank all the panelists, and over to Kashish. If we have some questions from the chat box, and if we have some time, the chair allows us to take that question. Else we can proceed to the next session.
So we have some time. I'll just display the questions, sir.
Sure. Okay, please.
Vinita, can you make some comments on the use of olanzapine, because that's come up repeatedly on the chat box?
Sir, I'll just unmute Dr. Vinita. Ma'am, you can unmute your mic.
Sorry. Yeah. Basically, it was to look at a cheaper option for CANV, and it turned out to be very, very effective in controlling nausea and vomiting, especially the even anticipatory and delayed nausea. So now I'm using it for highly emetogenic regimens and for moderately emetogenic with those risk factors we talked about. I typically start olanzapine the night before they're coming for chemo, and continue for 3 to 4 days, depending on how, and maybe I'll also continue for a week sometimes in patients who have had or who I expect a lot of nausea. But I've found it very useful, not just in nausea and vomiting, but also to control their mood, anxiety especially, and improves their sleep. And I have hardly come across any side effects. We do monitor especially in elderly patients, we do monitor QT intervals periodically, but I've not found any major issues with olanzapine. And recently there has been a study that uses lesser dose, 5 milligram. I have not tried it yet. I have used in a few patients who had liver dysfunction and all that, 5 milligram at a lower dose, and has found it to be almost as equally effective. But I still use the 10 milligram standard dose. And I believe giving it in the night will reduce the daytime drowsiness that was discussed in this patient.
Yeah,
We
thank
can
you.
take one more question and then wind up so that, yes, sir, we can, I think, wind up and take one more question and then I think Dr.
Yeah,
Sunil,
sure.
yes. From Dr. Aparna, palonosetron being long acting, what is the rationale of giving it alternate day? Dexona for 8 days is also longer than we give usually. It is the rational base. I agree, Aparna. In multi-dose regimen, it has a long life of around 72 hours. But people do repeat palonosetron. There are many studies where palonosetron has been repeated either at day 3 or day 4. That is a difference. But when you go for a 5-day regimen, definitely. Dexona, I agree with you, giving for 8 days and then repeating every 8 days in a BP regimen will be too much. Maybe after 5 days, but still, whatever the recommendation and guidelines are in a multi-day regimen,